Welcome everyone to the Perth and Kinross Integration Joint Board meeting of the 14th of December. My name is Bob Benson, I'm chair of today, and I'd like to welcome you all. And it's not exactly the best of weather outside. I can understand why it's easier being at home instead of joining us, but we've a good attendance today, which I'm really pleased about. But before I proceed any further, I just want to welcome a couple of new members. Martin Black is the new NHS Tayside non-executive voting board member, and he has joined us for the first meeting today. So welcome, Martin. And I'd also like to take the opportunity to welcome Dave Henderson. I think Dave, is that okay? It's not David, it's Dave, right? Okay, Dave Henderson, who's the new care sector representative. And I must say, I'm really pleased that you've joined us. It's the gap has been a bit too long for my liking anyway. So it's really nice to see you, and you come with a very good reputation, I might also add. So, do we need to do names around the board? It's Jackie Jensen's first meeting as well. Jackie, I believe you're online today. Jackie Jensen, who's another new member from NHS Tayside, as a non-executive member with voting rights. Okay, welcome, Jackie. I feel as if I've been welcoming Jackie for weeks now, but there it is. So I've almost forgotten. Thank you. Okay. Any declarations of interest for today? Thank you. And I'm also mindful today, and I nearly forgot to say, is that this is Jane's last meeting today, and we will ensure that we say all the nice things to her at some stage today. So I just thought I'd give you early warning, Jane. Thank you. Thank you. In that case, can we now move to item 3, which is the minute of the meeting of Perth and Kinross Integration Joint Board of 26th of October for approval. And you have a copy there. Can I have any comments on the accuracy of the minute? Okay. I don't hear any comments, so I'm assuming that the minute is accurate. And I would now like to seek a proposer and a seconder. Thank you, David. Seconder. Colin, thank you. That now takes us on to the action points update. Okay, well, we'll just go down through them in order then. 131. As we're waiting for, who's going to answer this one? Could I ask people in the room to switch their mobile phones to silent, please? Jackie, do you want to kick off with that one? 131.
Thank you very much. In relation to 131, a financial framework to support living life well, that work is still underway, and I'll address that in my update on mental health services.
Thank you very much, Jackie. And do you want to go on with the next 3 items, with the next 3 items as well, please? Thank you.
Yeah, thank you very much. In terms of action point 137, a communication protocol has been drafted with some updates to that draft and will be shared across the IJB for comment. So thank you to our communications officers for their work on that to date. Thank you.
Want to go on to the next one?
Yeah, 138, 3-year budget and a development session in relation to inpatient mental health services overspend. That remains outstanding, but we have a further 2 sessions in the diary around the budget, development sessions around the budget, and we'll pick up on that during one of those sessions. Thanks. 139. Together with yourself, Chair, we've had a number of positive meetings with our public partners in relation to voting status, and I'm of the understanding that a report will come forward to the next meeting to firm up on that. I also have an update in relation to the strategic planning group, in which the public partners will be invited to take on the role of co-chair.
We had a meeting in Edinburgh a fortnight ago with the chairs and vice chairs of IGBs in Scotland, plus senior officials from local authorities and the NHS. It was an excellent discussion and meeting, and since then we're moving forward. Our proposals for discussion has now been circulated to all 31 bodies, asking to come back with comments or other ideas. We'll be invited back next week to with the officers of the IGB to discuss with them what other steps we could take, they can take to work with us to make sure we get a really good response from the other IGBs. So thank you very much.
Thanks very much, Ian. And I should also say that Health and Social Care Scotland were also sponsoring that meeting, so that information would have gone into government as well. That's us. Okay, thank you very much indeed. Oh, Colin, do you want to come in?
Thanks. It was just to say that at the pre-meeting with senior officers for the IGB yesterday, we noted that there's actually a further action point to add on to the update, which is as a result of the consultation on the proposal to close services at the Blair Athol branch practice, we agreed that we would circulate the comments before and get agreement to the combined paper that was going forward to NHS for its consideration and decision on the matter to all IGB members before that went forward. So that's an additional action point which is ongoing, I think.
Thanks very much, Colin. Do we have any timescale we think that might be circulated? No. Okay. Well, we'll take advice when it comes. I don't know if Evelyn's got any update on it.
I've done some summation of the discussions, and I think I've sent them to you today, actually, in as an early sight of what the discussions involved. So hopefully we'll be able to build on that and get that round to IGB members quite soon.
Thanks very much. Thank you, Evelyn. So we'll get that out soonish. That now takes us on to matters arising. Are there any matters arising? Sorry.
Just for clarity, that action point that was being added, was that discussed at the 26th of October? Yeah. Yes. Thank you.
That takes on to matters arising. Are there any matters arising that aren't on the agenda today? Okay, thank you. We now move on to item 6, IJB membership and roles, responsibilities. and it's a verbal update by Clerk to the Board, Scott Henry. Thank you, Scott.
Thank you, Chair. Just to advise members on a couple of membership-related issues. Members will be aware that previously we had Lynn Blair from Scottish Care, who was a non-voting member of the IGB, as the independent sector lead. Lynn retired, and as the Chair's already mentioned, we now have Mr Dave Henderson with us, who's also now from Scottish Care, and the IGB has asked to formally appoint Dave as the new independent sector lead on the IGB. Following change of membership within NHS Tayside, there's now a vacancy on the Audit and Performance Committee for a voting member from NHS Tayside, and members are asked to consider this and will look to make an appointment at the next meeting of the IGB in time for the subsequent meeting of the Audit and Performance Committee. On the wider subject of IGB roles and responsibilities, as the Chair and Ian has already outlined, there'll be a further report coming forward in terms of roles and voting issues. In relation to this is also tied in with the standing orders of the IGB, which are reviewed annually. This would have been due to take place at this meeting. However, given light of the previous discussions, it was felt that a report should be submitted to the next meeting of the IGB that will take account of any roles and responsibility issues, but also some sort of more housekeeping matters in relation to hybrid meetings and the remit of the IGB. So it was just an update on that, and happy to take any questions.
Any questions for Scott? No. And I believe we now have to formally agree Dave's appointment. So Dave Henderson now formally appointed to the board. Thank you. Welcome, Dave. Right, thank you. That now takes us on to delivering on our strategic objectives, and the Chief Officer is now going to give us a verbal update on the strategic update. Thank you very much, Jackie.
Thank you very much, Chair. There are just 4 areas that I wish to address, and you've already mentioned that this is Jane's last IJB meeting in her role before she moves on to take up a new role outside of the IJB and the Health and Social Care Partnership. But I'm pleased to inform the board that we have an interim Chief Finance Officer appointment, and Donna Mitchell, who was a Senior Finance Manager, or is a Senior Finance Manager within the Health and Social Care Partnership, will commence in the Interim Chief Finance Officer role on the 23rd of December. And that will ensure that there isn't a gap at this very crucial time at the point where Jane leaves to take up her new post on the 8th of January. Sorry, the 9th of January, you're leaving on the 8th of January. So, and also to advise the Integration Joint Board that with the endorsement of both the Chief Executive of NHS Tayside and Perth and Kinross Council, I will now seek to address the interim positions across the Health and Social Care Partnership following a review of portfolios, and hope to do that by April 2023. In terms of the IJB's strategic commissioning plan, you will know that the IJB approved a 5-year strategic commissioning plan for 2020 to 25, and I intend to bring forward a proposal to revise the strategic plan mid-term by April 23 to take account of all of the impact of COVID, and also potential budget constraints that will be facing the IJB in taking forward its strategic direction for integrated health and social care. The Strategic Planning Group received a presentation at their last meeting in October on this very matter, and will be fully engaged in that process. As I mentioned earlier, the role of the Strategic Planning Group as the engine, if you like, the behind the strategic plan is a key strategic group assisting the IJB with its core purpose, and the important role of public partners and service users and carer representation on that group is not to be underestimated. And it's my intention, because I took over as chair of that group, I inherited that role when I took over as chief officer, and it's now my intention to invite a public partner to assume the role of co-chair of that group. So that's underway at this point in time. I also wish to give an update on the delayed discharge position in Perth and Kinross. You have before you today on the agenda the winter planning paper in terms of our preparedness for winter. But I would like to advise the board that following a presentation on delayed discharge and our discharge without delay improvement work, that it remains a challenge in Perth and Kinross to reach our agreed targets in relation to delayed discharge, mainly from the PRI site at Perth Royal Infirmary. I'll acknowledge here formally that staff and managers have worked determinedly across the whole system, and although we're in a much improved position and we've moved from red rag status to amber status and are hovering around that, that's not an entirely stable position, and the demographics that we face in Perth and Kinross and the complexity of need and our inability to recruit and provide the levels of care at home that's required to meet that need is becoming a long-term issue for us. And one of the key areas that we'll be looking to is communications with the public around expectations and how they can support that. So it's really just to draw that to your attention, and I know that Amanda and Evelyn will refer to this when we discuss the winter planning paper. So those are the 4 areas that I would like to draw your attention to today. Thank you.
Any questions for the Chief Officer on that strategic update before we move on to the Mental Health Services update? Ian.
I apologise if we've given an answer to this question previously. The COVID-19 and the continuation of cases, and in particular those who have had discharge from hospital, are still involved in the long COVID debate, and each of those kind of cases are quite individualistic, and the length of time of provision for them at this stage, I assume, is uncertain. Now, previously we had a reduction or taking back pension, what we want to call it, the quite a few £1 million which had been allocated for COVID services. And given that we're going to have to continue with these, is there any possibility of us asking for that money back to ensure that we do actually have going forward adequate resources for rehab, treatment and other aspects of mental health aspects of people who've got long COVID?
Ian, I wonder if we could reserve that discussion for the budget update. Thank you. Jackie.
I would add to that we have been involved in discussions around ongoing support for people experiencing long COVID, and there is dedicated resources flowing through NHS Tayside, which will support our local services in this area. And it may be that a briefing on that at a future meeting would be helpful to give you an insight into the extent of that.
Ian, if you're content with that answer. Okay, thank you. No, it's fine. Okay then, that takes us to the mental health services update.
Thank you very much, Chair. The update for today's integrated joint board is a verbal update, and I intend to talk you through some slides which will be coming up on the screen just shortly. The report follows on from, or my verbal report follows on from the report that you received at the last meeting on the 26th of October. And I'd like to bring you up to date in relation to the coordination of strategic planning, which, as you know, is delegated to this IJB as lead partner within the integration scheme, and also bring you an update in relation to Listen, Learn, Change and the work of the Independent Oversight and Assurance Group. The reason that this is a verbal update is that this is a continually changing picture, and in the last less than 4 days I've had a series of engagements, the most recent of which was this morning, and some of us who are around the table here at the IJB took part in that as part of the programme board for mental health and wellbeing, and so it was important to be able to bring this to your attention as soon as possible. A similar report will be provided to NHS Tayside Board at its meeting tomorrow. In terms of the lead partner role, the last report indicated that we would be taking forward work to finalise a streamlined structure and to re-evaluate and reprioritise the current work streams for Living Life Well. Update the terms of reference for the Mental Health and Wellbeing Programme Board, and the review of governance is almost complete. It's still underway, and as I've said, I've taken soundings from Tayside executive partners, a strategic leadership group that has been put into place, members of the Integrated Leadership Group, which is senior managers across mental health and learning disability services, the Mental Health and Wellbeing Programme Board this morning, the Angus IJB on the 7th of December, and also intend to take soundings today and from yourselves, and I'm awaiting a date for a discussion with Dundee IJB. This slide that you see here, really on the left hand side, it's very small writing for those that are trying to read that in the room, but basically it's a quotation from a letter to the Tayside executive partners from Fiona Lees as chair of the Independent Oversight and Assurance Group, stating that the current position across the programme was leading to, it was complex and leading to system paralysis, and that's a quotation from her letter, and that the governance structures were overly complex, and it was unclear as to who had responsibility for what. So this slide also indicates those areas that we have moved forward on in terms of the revision of the integration schemes and clarity around that, clarity around the use of directions from the Perth and Kinross Integration Joint Board as lead partner, and still working on how we ensure that the Angus and Dundee IJB members and NHS Tayside board members are appraised of that. A new programme team has been appointed and inducted, and so we're making progress in relation to addressing the deficiencies that were reported to us by the Independent Oversight and Assurance Group. Can we just move on to the next one? So, and in this work, it's important to recognise that there's the Listen, Learn, Change Action Plan, which relates to the 49 recommendations for Tayside in the Strang report, we have the Living Life Well strategy and a need to refine our priorities. And if you take the actions that are sitting across these schemes, it's very, very complex. So refinement of priorities and ensuring delivery on key areas. So we could just move on to the next slide. So in terms of that unrealistic structure and which is leading to system paralysis, this is the governance structure that is set out in the current strategy for mental health and wellbeing for Tayside. And I think if you can see this, you don't need to see the detail of it. You just need to see the complexity of it, because there are currently, or there has been 31 work streams working underneath the strategy. And there's a proposal to refine this down into probably 5 key areas, and I'd like to take soundings on that from you. Next slide, please. What's missing from that governance structure is the role of the Perth and Kinross Integration Joint Board with responsibility for leading the coordination of strategic planning. So this is an opportunity to reset that and ensure that the governance structure takes that into account. The Tayside executive partners are the group of the 3 chief executives from the local authorities, the NHS Tayside chief executive and the area commander, who came together in response to the Strang report and set out a promise that's in Living Life Well. But in terms of responsibility for decision making and issuing directions in terms of the strategy, that rests with the Perth and Kinross Integration Joint Board. So the proposal is that the Tayside executive partners would become advisors to the strategic plan rather than being responsible for or accountable for it. And the proposal also is to introduce a new strategic leadership group, whatever that might be called, but it would require involvement of the 3 chief officers for the health and social care partnerships, the medical director, the executive director of nursing, and likely to include the director of finance or their representative and the director of property services in NHS Tayside, because of the requirement to have a financial framework to support the delivery of the plan, and also in recognition of the fact that services are delivered out of buildings, and there's likely to be a need to change or improve or revise the environment in which these are produced. So that's just there for now for you to consider. And move on again. The leadership group across mental health services has done some work to reprioritise the 31 work streams as sitting there, and this is really a slide that shows how there's the kind of greying out of certain areas of work. Now that's not to say that they disappear, but some will report in a different way. So for example, the improvement around services for children and young people through CAMS has a reporting structure through the Women and Children's Directorate and the Children's Service Planning Arrangements. So it perhaps can grey out here and not be a priority for the Living Life Well programme because it's being taken forward in a different way. So once you have a look at all of this and refine it down, move on again. It's very small writing, and I apologise for that. Can you see it okay? It refines it down to 6 projects, and the 5 that are highlighted there are the 5 areas that there seems to be. What's coming forward is almost universal agreement that these are the 5 areas that we really need to focus on. So there you'll see the crisis and urgent care pathway. So that's responding to people in in immediate crisis situations. Integrated substance misuse and mental health services, and bringing these two together wherever possible, because there's a large degree of overlap in terms of presenting need and between substance misuse and mental ill health. Specialist community mental health redesign. So that's the important role of our community mental health teams and our own strategic plan for mental health, and how those can be streamlined and clear pathways into acute services and back out again. So I really describe that as a getting it right approach for adults with mental health, with mental ill health. Adult mental health inpatient redesign. So that's looking at the shape and scope and provision of inpatient services. It doesn't say single site, because it's actually about saying let's look at the whole redesign of this. And then the other area that's highlighted is a whole system redesign of learning disability. So that's inpatient services and what's available in the community across all sectors. So those are the 5 areas that are being highlighted as key priorities for the programme that will support the delivery of Living Life Well, and likely to be the key features within the strategic direction that comes back to the board in March. The discussion this morning looked at community engagement and expanding that out to include co-production and co-design around all of these work streams, not just about engagement. So it's that movement from consultation and engagement to actual working together to reshape these services, and that the workforce subgroup, which these are 3 enablers really to the programme, would also highlight the importance of addressing the cultural dimension and include that in there. So this was really just to bring this, and that's why it's not in a written report, because I think it's helpful to have a verbal introduction to this before you see further detail in writing, really just to pick up on any comments or thoughts that you might have. Thank you.
Can you switch your? It's okay. Thanks very much indeed, Jackie. There's so many different things within that. Are there any immediate questions that folks have for Jackie around about that direction of travel? Okay, I'll take those online first of all. Sandra Auld and then Beth.
Thank you very much, Chair, and thank you very much for that, Jackie. My first point is actually coming in on the back of earlier discussion about service user involvement in the IGB. I was struggling with remembering that we can't raise hands and fiddling about with that, so I missed the opportunity. But it was just to make the IGB aware that Ian and myself have been working quite hard to raise the profile of the IGB with local community groups, including the local community councils in Perth and Kinross. And so we've now contacted all of those groups to alert them to the IGB's existence and our role on the IGB, and to be there as I guess a conduit for information, and making it clear that this is for positive feedback as well as everything else. And on the back of that, Ian and I were invited to present at a local meeting last week. And arising out of that, there was a question that came from one of the councillors that attended regarding mental health services. So hence my link into Jackie's presentation. And the question that was raised that had been fed back to him from a constituent was about the lack of availability of dementia beds locally. Well, not locally per se, but in Perth and Kinross. And the fact that he was aware that there is a wing at Parkdale Care Home with that's not being used, and he asked about the likelihood of that changing. So I said it was something I would raise, and Ian and I are just setting up a meeting to discuss this further and to understand more. But I thought it was useful just on this topic to feed that back.
Thank you much. Thank you very much, Sandra. And firstly, thank you very much for continuing your engagement at a local level. I really appreciate that. Jackie, do you want to deal with the content of the questions, please?
Thank you very much, Sandra. And first of all, what I'd like to say is that the support for people experiencing dementia and psychiatry for people in old age is actually part of our older people's strategic delivery plan. And so therefore we will be planning that on a local basis. So the discussions will take place here. And I know that Christopher Lamont will be giving an update on an annual update on our local mental health and wellbeing strategy. So it's really just to ensure that that's understood. But secondly, your point about a particular establishment that is within the control of the Health and Social Care Partnership and the council at Parkdale, that is certainly something that we're considering in our proposals that we were bringing forward, associated with some of the budget discussions that we're having in terms of our strategic planning. So we've already got that in our sights, Sandra. Thanks.
Okay, thank you very much. That now takes me on to Beth Hamilton.
Thank you. Thanks for that, Jackie. I found that really interesting, especially I agree with Fiona Lee's comments about the complexity of the whole current system as was. First comment I would make is really an early warning for you. Just when you were going through that, there was very little mention of staff side engagement. I know we talk about leadership, etc., and different partnerships, but if you're taking this to the health board, I would suggest that you might want to include there some of your plans for partnership engagement with staff side from NHST side, certainly then reflecting on the attendance from mental health at the staff side partnership conference as well. So I just want to give you that heads up before you present tomorrow. Second point I wanted to make was your projects. You picked up the 5 top projects. One of my concerns around that is the workforce is not one of the top priorities, and from what I've been hearing in some work that I've been doing lately with tribunals, etc., it might be worth acknowledging that workforce is a priority, because the workforce situation is one of the big risk areas to the delivery of the strategy in local services and national services. And the last thing was a question. You mentioned about the inpatient redesign and the learning disabilities redesign. Are we going back to square one again, or are we working on the information and the work that's already been done? Because that gives me a bit of concern that this is an issue that's been done on a regular basis for the last 25 years that I'm aware. So it was just, are we going back to square one, or are we going to work on what we've already done?
Thank you very much indeed. And I think the first 2 questions around staff side, I think, were raised at the last NHST side board meeting as well, as I remember. Jackie.
Well, thank you very much. And it's probably trying to present this and get the coverage and not the detail. I have omitted to say that the employee director and NHST side has been involved in the discussions.
And I thought you would do, Jackie, but I'm just giving you pre-warning of what to expect if you don't specifically mention it.
and is supportive of the direction of travel. So it's and that's why this is, I see this as not as providing a report with the answer. It's very much about saying, are we all on board here, and we all facing in the right direction and going in that direction? So thank you for that advice, and it was really just to advise that we've already had some of those discussions. I hear what you're saying about workforce, Beth, and happy to pick up on that, and we'll take that forward as part of our ongoing deliberations around this. And only to say that I would agree with that, and the 5 priorities are not set in stone. I think it was trying to get it down to a manageable number, but I mean, without staff, then there are no services to be delivered. So certainly it's at the core of what we need to do. And then your question around inpatient redesign, that's exactly the views that were coming forward at the programme board this morning, particularly from members of the stakeholder participation group and their involvement in previous work with the Cape Bell and others before. So folk were not wanting to go back to square one, but recognising that there may be changes may have happened since March 21, when it was agreed to set up a short-life working group around this, and not going back to square one, but recognising that the context may be different. It maybe have deteriorated in some areas, and it may have improved in some areas, but just a recognition around that. So I suppose the answer to that is no. But we need to recognise that some things will be different.
Okay, thanks for your answers, Jackie.
Sheila McCall.
Thank you, Chair, and thank you, Jackie, for that report. It's very helpful, and I'm pleased to see that one of the priorities is the community mental health strategy. I just want to be clear that that includes outpatient services that are delivered from Murray Royal.
Yes, it will do, because that whole redesign is about the pathway from supporting the community, and it may require someone to have a period of hospitalisation and then a return to the community. So there's something in there about making sure that people have that constant support throughout. So yes, it will.
Yes, that was my kind of follow-on question, is about although we're talking about inpatient and community mental health services, there's a significant overlap in each of them. And I just want to be assured that when these work streams are in progress, that they actually work with each other as well, to make sure that the transition from one to the other, and often in repeat occasions, is aligned, and it's not, and it should be seamless for the people using the services. And also for the learning disability strategy needs to feed into that as well, or redesign. Because I think sometimes that the transition from one to the other, and indeed when you're looking at people with learning disability from children to adult services as an extra layer of complexity there that we've spoken about before, that it's really important that all of these work streams, although they're individual work streams, they need to be aligned completely, and the process flows and maps that are developed need to be agreed entirely and seamless. So if you can give me that assurance, I'd be very happy.
Thank you very much, Sheila, just to say that's good advice, and yes, happy to reassure you that those are the very areas that we're planning to take forward. Yes, thanks.
Thank you, Chair.
Colin Stewart.
Thank you, Chair. So as the Chief Officer asked for feedback, I'll provide it. I entirely understand the point about the complexity of that slide. When I first looked at it and first had sight of it and tried to zoom in to actually read anything, I was horrified by the complexity of it, if I'm honest. I mean, I can absolutely see why it leads to paralysis, so I'm fully supportive of the attempts to narrow that work down, separate out what is business as usual, and to focus on those 5 selected key priorities. I think they're absolutely the right ones. In relation to the point about workforce being a priority, I think that would actually apply to any of the work that the Health and Social Care Partnership does. And if I'm not mistaken, in your written report fleshing this out to NHS Tayside Board tomorrow, you've actually identified some underpinning principles, including workforce and I think finance as well. So that's already sort of taken care of in the sort of full written report. But these are the priority areas for work where it needs to develop, supported by those underpinnings. In relation to the point about governance, one of the things that concerned me looking at that first complex slide was about the presence on it of unconstituted groups without terms of reference and without reporting lines. So I'm pleased to hear that part of what we're taking forward is governance with proper reporting lines and decision-making authority. And on the point about the redesign, I think you said without wanting to go back to March 21, but we could go back at least as far as June 2017 in terms of the bringing forward proposals for a redesign of the inpatient mental health and learning disability service. So while accepting that we don't necessarily want to go back to square one, I would certainly think that in that 5.5-year period, there will have been developments around the requirements for inpatient care and around what might be considered a therapeutic environment, which will require a review of the current provision. And I'm conscious of the work that was done at various points between June 2017 and now, particularly with regard to the short life working group and the options appraisals which were developed. But again, none of that has sort of coalesced or materialised into a proposal which has, which has come before us for challenge, for questioning, and for giving a strategic direction. So I look forward to that coming back. And I think we've already noted in the forward plans that will be something that will need to come back to the board. Thank you.
Thanks very much indeed. And Colin, I also would have commented on the strategic governance issues around TEP and others. That's been a big step forward in getting clarity around these roles, as we've tried before. So it's an excellent move forward. Sally.
It was just to say that I really like this, and I really like the work streams that have been prioritised. I completely agree with Colin, and certainly anecdotally frontline, these are the key areas that we see day to day that need to be prioritised. The other thing as well that I'd be really optimistic about is that this will actually lead on to improvement in other work streams, and if we can get these right, then we should see the natural development of other key areas. Obviously, I'm always thrilled when I hear the words co-production and co-design, but my query is, which there might not be a right or wrong answer, which I think is always a challenge, is how do you balance the fact that it is going to take time to do true co-production, co-design and true engagement with the need to stick to timelines, but also the frustrations of maybe understandably the public who feel that things aren't being improved quickly enough. And there may not be a right answer, but it feels as though this is a recurrent difficulty with a lot of these things.
Yeah, no, thank you very much, and thanks for your comments on that. It's really good to hear from your perspective, from general practice and your experiences there. What I didn't say in my update was that we've progressed with the support from Columba 1400 around some leadership relationship building experiences between senior officers and members of the stakeholder participation group who represent people who use services and people who care for folk who use services, and the the very positive comments that have flowed from that, which is about let's sit down together as human beings and achieve a shared common purpose, and what is it we're trying to achieve, and let's work to some realisable aims around that, recognising it's a long-term approach, and also wanting to extend that out further to others, and in the new year. So I think we've kind of laid some really strong foundations for that with a group of 10 people. So we need to build on from that. But I think in terms of co-production, we will seriously need to look at what resources are we bringing in to support that. It doesn't happen easily. It takes a lot of time to do that. So I would hope that we can think about how across this bigger partnership that we have, that we can actually seriously resource that. Thanks.
Thank you very much indeed. Maureen, did you have your hand up there?
I would just like to go back to a remark that Jackie made to say that the single site is not in the redesign, because we were led to believe 2 years ago when Kate Bell left us that there had to be a single site because they couldn't finance 2 sites, and they couldn't put worker. They didn't have staff to go into 2 sites, and it just wasn't sustainable, and that we had to go to a 1 site, and that was why there had to be a subgroup set up to look at the other possibilities for a single site, because it was generally agreed that Carsview wasn't ideal for people in crisis, and that's so we're to look at other options. And that's what's never happened. That is the frustration with a lot of the people in the stakeholder participation group. They're all people with first-hand knowledge of some of the tragedies that's happened at Carsview, and not historical ones. We're talking about quite recent ones too, you know, tragedies, and that the whole thing is not ideal. So we need to urgently, can you tell us if in the longer term, or even the shorter term, maybe the next 4 or 5 years, that it will continue with two sites, Murray Royal and Carsview, and if not, what their plans are?
I was being very cautious, Maureen, because I was thinking about the context that was reported here previously, which is seeing a site as Carsview, if you like, with an occupancy rate that is much higher than the recommended rates. And that's not the position that would have been reported when some of those earlier decisions were made. So we need to recognise that, and that's why I was being careful about it. But in terms of a decision, the role of this board in directing NHST side is going to be crucial. So it's about the information that this board will require to make a decision about what is the shape and scope and future direction for inpatient mental health services, and to use its authority to direct NHST side to deliver it. And that's what we need to come forward. So this is not me making a decision about this. It will be for this board in collaboration with the other IGBs and NHST side in order to reach that position. And in the new year, we need to bring key members of the IGBs together, along with board members, to decide what's that going to look like to be able to achieve that. So the decision making actually rests with the IGBs, because it's been delegated to us. The strategic plan, coordination of the strategic planning for inpatient mental health services and inpatient learning disability services rests with us as an IGB.
What I'm trying to say is that, you know, it's been 2 years already with nothing happening. Okay, we've had COVID, but we've still had online meetings regularly, like, you know, and there's still been discussions and decisions being made, and, you know, we're actually no further forward, and we don't know, even in the short term, what's going to be happening, you know. And this is why I'm a representative for unpaid carers, and I feel I need to be able to feed back to them that there is some progress being made, and I've nothing to report back.
we just note that comment, Maureen, rather than respond to it. I think your first question enabled Jackie to give the more fuller response to it, but I think it's in all of our minds. And I know that Jackie will be reporting the NHS Tayside Board tomorrow, and we are seeking much higher level of engagement across the board, as well as with the senior executive team. And that would be one of my priorities as well, with both hats on. Martin.
Thanks, Chair. Thanks, Jackie. And it's really encouraging that one of the tracks that you've done is about engaging with communities and bringing them along with us. That's important, really important for any future delivery. But on your first slide, you had the strategic group, and then you had the Perth and Kinross, and then you had principals across here pointing the arrows towards. There was no arrows going backwards. So where's the accountability? Where's the accountability? Because you've got direction, as you quite rightly say, the IJB has got direction.
I'll fix my diagram, Martin.
But your point's well made. Okay. Thank you, Jackie. And unless there are any other questions, but I think that's been quite a helpful update, as I'm sure you'll agree. But I just, oh, sorry, Jen, I didn't realise you were coming as.
No, it was just around representation on your group, Jackie. I know we haven't had an opportunity to discuss it. You've talked absolutely about the IJB in Perth and Kinross having decision-making responsibility for strategy, and within that there is financial strategy. So my wish, my parting wish would be ensure that there's the Chief Financial Officer for this IJB sits on the programme board to ensure that the resources required are given strong prominence, and CFO can give this board strong advice on the resource implications moving forward.
Point made. Ian.
Right. Technology. This is the second time I've had a report, or we've had a report on mental health. And the first one set out a clear direction of what we're doing. And I think this is taking it a step further. We'd all like to live in a world where we could just scrap what's there and start next day. We're going to have to manage the issues around the past and the present to get to the future. And it's with that in mind I'd like to ask a question. It was on page 17 of 84, and it's about the digital technology, but I'm not going to ask about that. It's interesting figures. It relates to people, the number of people waiting more than 52 weeks, which is 159 at the moment. Oh, it's the next one. Okay, I apologise. You know what I want to say though.
The cat's out of the bag now.
Sorry, Bob. Oh.
No, thank you for that. At least we now know page 84 is in the frame. But I just wanted to thank you for that. But also, I just wanted to say how important this whole issue is about managing expectations from everyone. But what I'm really pleased with within the discussion was this. It started off with one question around engagement at local level, and then it transformed into the wider issues that Jackie was dealing with as well. So something about that flow through of communication, so that you can go, folk like yourself, and can go back to stakeholders, and Maureen can go back with a clearer narrative on this, because that's what one of the key issues is. Thank you very much. I'd like now to go on to the annual update on community adult mental health services. And this has been led by, is Amanda? It's not you. Sorry, I'm ahead of my winter planning paper. Sorry, Amanda, don't want to shock you. Evelyn, thank you.
Chair,
Okay, sorry.
This has been led by Chris Lamont, who's online, and he has a short presentation for you.
Thank you, Chair. Thank you, members. I should have let Amanda deliver this. That would have been fun. And I've got a strong suspicion that there might be a question getting raised about digital technology, but I might be wrong. I always know when I'm in the presence of the great and the good because my chief officer always calls me Christopher. So on this occasion, I'll revert to my Sunday name as Christopher. So welcome, everybody. I'm going to give a synopsis of the paper that's already been submitted and seen by members of the IGB. So please bear with me. Can I get the next slide, please? So the recommendation within the paper is obviously to note the local and Pan-Tayside developments that are being progressed in accordance with our local community mental health and wellbeing strategy, and hopefully approve its continuation and direction for year 2. But also to acknowledge the numerous and complex factors that have been influencing this work. And Jackie's already touched on some of those with her previous presentation. Next slide, please. So, as many people on the call will be aware, adult community mental health services across Scotland over the last 10 years, I'm sorry, I'm just going to put my camera off as well because I'm having some IT issues. Over the last 10 years or so have gone through considerable change. With the shifting of balance of care agenda and a focus on reducing acute admission beds, community mental health services have witnessed an increase in referrals, but also the level of risk associated with their caseloads. As we've already heard, the Trust and Respect report that was submitted in 2020 highlighted the need for broader and more effective engagement, coordinated strategic planning and urgent operational improvements. And this, coupled with the competing priorities that we are now facing regarding resourcing and recruitment, how local adult CMH community mental health services have had to start changing the way in which they deliver mental health care. Our local community mental health and wellbeing strategy for P&K has been a platform for this, and these have brought about significant changes over the last 12 months, which I will go on to throughout this presentation. It's enabled us to start moving in a direction of travel which will hopefully be more sustainable and person-centred for the future. And as you can see, the 5 key themes across our mental health strategy, which many of you will be well versed in, are good mental health for all around early intervention and prevention, access to mental health services and support, coordinated working and person-centred support, participation and engagement, and review of workforce requirements. We've also taken forward some changes around utilising advanced nurse practitioners within our mental health and substance misuse teams, working more collegiately with third sector colleagues, and starting to develop a primary care mental health model, which I will come on to later in the presentation. Our mental health and wellbeing strategy group, who oversee the mental health and wellbeing strategy, has a wide variety of membership across our key stakeholders, including third sector service users, statutory organisations and voluntary groups, some of whom are actually currently in the room or online as we speak. Learning and experience from the pandemic around collaboration, compassion and understanding of needs has been taken forward, and we have learnt significant amounts from this time. And so Sally is happy with the words. We have been using some co-production at the foremost of what we are trying to achieve. And with this in mind, the group is currently chaired by myself, but also vice chaired by a staff member from third sector organisation as well. So progress to date. We've started a mental health directory of all services, including statutory and third sector organisations, and this continues to be developed, and it's been driven forward by one of our key theme target groups, which is being led by a member of the voluntary sector. And this is embedded in the paper that you've all got access to as Appendix 1. We've recruited a suicide awareness and prevention coordinator, which is now a dedicated resource, and this individual has been in post since April. And on a side note, Education and Children's Services have also recruited a specific suicide awareness and prevention coordinator as well. Therefore, we have a joined up approach to suicide awareness and prevention across P&K and across all age ranges. This role is key to the planning and delivery of training, as well as data gathering around suicide rates across P&K, and we are currently in the process of developing a collaborative training package with the School of Health Sciences at Dundee University, which we're hoping to start delivering come the beginning of next financial year. We've started to improve our enhanced physical health monitoring processes within our teams. We've commenced weekly physical health monitoring clinics. These are getting delivered by our community mental health nurses across all 3 localities. And these clinics aim to identify early symptoms of physical health and offer support and advice on how to avoid any ill health progressing. We have started to develop pathways around our substance use and mental health issues. And as Jackie's already touched on, across P&K, we're trying to develop and have already embedded an integrated substance misuse model. The development of the pathway around substance misuse and mental health will ensure that individuals will receive appropriate treatment irrespective of their presentation. This corresponds with the MAT standards, and the service is working in a much more integrated fashion, with both health and social care staff being amalgamated on one site with one operational manager, but I'll come back onto that at a later date. For Ian, we've increased the use of digital technology for consultations and waiting times. We've increased the availability of digital technology to service users, particularly in our rural areas, and this has proven to be very effective, particularly for consultant psychiatrist appointments, and it's also enabled us to be more flexible in our support. There has been a decline in individuals waiting to be seen, and there's been a reduction in those waiting over 52 weeks for an appointment. And this is despite an increase in referrals coming into services, particularly what we noted back in September. We have also, as part of an NHS Tayside service, embedded our perinatal mental health service. We now have a dedicated resource within Perth and Kinross to deliver perinatal mental health care, and it's acknowledged for some time now that this has been an area that's been requiring development, especially when we see that 27% of new and expectant mums develop perinatal mental health problems. So that's a very welcome asset. Next slide, please. Mental health practitioners, we've commenced the development and recruitment of advanced nurse practitioners within our community mental health teams. The role of the AMP, for those that aren't aware, is to provide expert advice and treatment relating to complex mental health issues, and we have already seen a reduction in those waiting for ADHD assessments within Perth City due to this role. KPIs, so our key performance indicators for mental health. We've recently developed a range of key performance indicators as well as performance framework for mental health. At this point, I do have to acknowledge the input and the hard work that the business improvement team have supported us around this. And an example of what the KPIs are, albeit it's in draft form at this moment in time, is in Appendix 2 within the document. We are hoping to have this formally signed off within the next month or two, and we've been in discussion with Angus and Dundee about making this a Tayside-wide performance framework to see whether or not we can have a whole system approach towards this. We've embedded distress brief interventions across Perth and Kinross. This is a commissioned service that came into being in April of this year. It's a key action within our local mental health and wellbeing strategy, but it's also a key action that the Scottish Government have advised all HSCPs to embed within their services. And we are currently in negotiations around how we can expand the referral routes into the service, because the uptake hasn't been particularly high, albeit the local police are currently using it to some degree. We have a localised crisis support. So for those again on the call and in the room will be aware, we currently have the NUC that's based in Perth City, delivering 24/7 crisis support, 365 days per year. The NUC also has, for anybody that isn't aware, other services embedded within there, including Distress Brief Intervention Service that's being run by Penumbra and the Lighthouse Project. And we know for a fact that the police have been using it with particular emphasis around a place of safety, but also so local triage can take place there. And the NUC have been working in very close proximity with our community mental health services. Action 15. This is one of our key successes over the last 12 months, albeit Action 15 has been in progress over for a 4-year period. We received initial funding to recruit 21.8 individual additional posts across all avenues of mental health, including third sector. We hit the target way before the end date, and we were so successful that the Scottish Government actually contacted us and asked if we would be able to recruit additional staff, and we ended up recruiting 45 posts or individuals across the whole arena. At this moment in time, we are hoping that Action 15 funding will continue, but as with most other things, we're still waiting for confirmation from Scottish Government. Our local mental health service redesign. Over the past 6 years, 6 months rather, the Health and Social Care Partnership has undergone a redesign of our mental health and affiliated services under one structure. The primary aim of this redesign is to move towards a more transformative model of care, and this has already enabled us to embed an integrated substance misuse service. And as I've mentioned earlier, this incorporates our health teams, our social care teams, and has one operational manager now overseeing the service within the Drumheart Health Centre. Within the next 6 months, we're also hoping to have an integrated learning disability service, which will again be health and social care under one operational manager. And we are currently exploring a single point of contact for all referrals coming into our mental health services across P&K. And this is in regards to the remodelling of our primary care mental health services. And next year, we will be actively starting to look at our Psychiatry of Old Age transformation programme as well, which will include working more closely with our third sector colleagues. This will also be supported by our recently appointed project manager and business improvement team. So hopefully we can start making some clear headway over the next 12 months regarding those additional transformation programmes that we've now earmarked. Just a side note regarding third sector organisations before I move on to key challenges. It's worth noting that our third sector contribution into our mental health services is invaluable at this moment in time, and I've already touched on this around their input into the Mental Health and Wellbeing Strategy Group, as well as the work that they currently undertake. We have approximately £500,000 worth of funded commission services, and this is outlined within our annual commission services report, which people can receive a copy of if they want to. And there is also an additional £400,000 of current funding being made available through the Community Mental Health and Wellbeing Fund, which is overseen through PCAVs. So again, I really just wanted to highlight the additional resource that's going into third sector, but also how much we are reliant upon their input in driving forward a lot of the key priorities within our strategy. You'll be glad to hear I'm coming to an end now. So the key challenges, although there's only 3 key challenges outlined, each one is huge. They're significant, particularly with what's been happening that people are very familiar with. So recruitment and retention of staff is arguably our biggest key challenge at this moment in time. It's a red risk on our partnership risk register. As people on the call will be aware, this is a national problem, not just affecting mental health, but across all services. And again, I used the term the last time at the IGB Development Day a few weeks ago, but everybody unfortunately seems to be fishing from the same pond. So it's how we can make the service as most attractive as possible. We've been exploring ways and means of how to mitigate this risk. So for instance, we're exploring how we can maybe take on board some GP specialist roles. I've already mentioned around allied advanced nurse practitioner roles. We're looking at associate practitioner roles within our CMHTs who are band 4 members of staff who are coming in and doing some level of training, but not actually at the same level as a registered nurse. And obviously, we're also looking at how our AHP colleagues can also move into some form of an advanced practitioner role, particularly around prescribing pharmacists. We are keen to develop the primary care mental health role as well, albeit this was something that's been earmarked by Scottish Government for all areas to progress. And initially, there was some potential additional resource coming our way. There's now a level of uncertainty around that, a significant level of uncertainty, but we still have a plan in place around how we can start to pool our current services together to formulate this model. We have winter pressures and increased demand. I'm not going to spend too much time on this because I am aware that Amanda's coming in around the winter planning process. But it is worth noting that over the last 2 years, we have noticed that increased winter pressures appear to be accumulating earlier than the traditional winter period. Across P&K, 60 to 75-year-olds are increasing from 19% to 22% across the general population. And again, the percentage of people aged over 75 is rising from 11 to 15%. So as you can see, this will continue to keep putting additional pressures and stresses within the system due to the complex requirements of some of these individuals. Within mental health, we continue to experience delays for patients requiring discharge from inpatient services. This is primarily due to requirements for supported accommodation or increased care packages. And to help mitigate some of those issues, we have actually employed 3 additional social work assistants to support the discharge and planning process back into the community. I mentioned earlier that referrals within our community mental health teams have actually consistently continued to increase. And to give an example around that, in September of this year, there was a total of 260 referrals that came into all of our community adult mental health teams, including POA, psychiatry of old age, and that was across the 3 localities, and that compares to 190 referrals in January of the same year. So as you can see, there is actually a significant increase in referrals coming into the service. And there has also been a noticeable increase in referrals relating to individuals requiring ADHD assessments as well. And the final key challenge there, and it'll come as no surprise, is obviously the future financial challenges. There has been significant detail and discussion over the past few weeks around the financial situation, and I am aware that Jane's coming on to do a paper later on the agenda. And obviously within the paper that members currently have access to, there is a detailed financial section laid out in there, which I really don't need to go into too much more conversation around. But the potential and the likely impact of these challenges is that some of the proposed development outlined within the strategy may well have to be put on hold or tweaked, depending on what we find out regarding the future financial position over the next few weeks, coming days from Scottish Government. Next slide, please. So my final slide, just around the conclusion, is that, as has been discussed, there is significant progress within the first year. This is in no small part due to the collegiate working between ourselves and third sector colleagues. There has also been significant investment within our services, and any risk to future funding streams will be managed through the 2023 and 24 budget process, which was already going through at this moment in time. It is apparent that given the recent budgetary announcements and the ongoing national difficulties being faced with recruitment and retention, that we will see increased pressure upon our collective services, and I think that that's unavoidable. We will continue to work collaboratively across the whole piece to ensure that we deliver the best possible services across P&K. Thank you, and I'm happy to answer any questions.
Thanks very much indeed, Chris. Jackie, is there anything you want to say before I open it up? No. Okay, I'm opening up for questions now. Thank you very much for that quite significant progress. Sally.
Thanks, Chris. I just have a couple of queries. I was really interested to hear about the remote consultations that you're doing. And it's just a quick comment just to say that it would be, I think it's really important for, if they're being used by the psychiatry service, that there is also a recognition by psychiatry that these are also acceptable ways of assessing a patient within primary care. We sometimes notice there's a little bit of an obstruction there, that we're using remote for psychiatry, particularly if we're referring on in an urgent situation. So I think there needs to be a recognition that if they can use it within one service, we can use it within another. The other quick query I had is I'm always really interested to hear about things like the primary mental health service and the use of different practitioners, which I think is always really positive because of their skills. However, there's sometimes we find within primary care, particularly around issues such as prescribing, referral, admission, that actually, because there is some difficulty with full completion of tasks, it actually increases primary care's workload, because a lot of it comes back to us to complete it, and the space that that patient has given to us is instantly filled by someone else. So had you got any thoughts about how we can ensure that doesn't happen within these new models?
So the first point is I wasn't aware around the digital consultation within primary care and psychiatry, and obviously having different rules for different people. So I'm happy to feed that back, Sally, and take that forward. And I can certainly speak to our GP lead for mental health around how we can sometimes look at this as well. So that's the first thing. Regarding the increased workload for primary care, when we've already put in place primary care mental health practitioners, again, I can take that back to the operational managers and the operational team and have a look at how we can actually improve that. I am aware that there are some issues at this moment in time around access to consultation space for some of our primary care mental health nurses within GP land, and that is something obviously we'd be quite keen to address as well, just to try and make sure that the nurses are on site to try and have that open dialogue and communication at all times. But again, I appreciate that space is at a premium at this moment in time across all areas. So again, it's just something that we're just going to have to try and live with at this moment in time.
That's great, Chris. It was just more, I completely appreciate what you say about space, but this is more also about ensuring that tasks can be completed rather than it coming back to primary care to have that completion. So, for example, we may have a recommendation regarding starting antidepressants, but unfortunately the staff that have been put into our service can't do that. So therefore the workload comes back to us rather than it being a completed task within primary care. And, you know, that's fine, but with the new primary care models and the primary care mental health service and hubs and that sort of thing that have been talked about before, we need to ensure that full service tasks can be completed within that hub rather than having to come back to us to do prescriptions and that side of things.
Yeah, no, absolutely. I can take that back.
Thanks very much indeed. Sarah Dickey.
Thank you very much, Chair, and thank you, Chris, for your paper. I've got a couple of comments and then a couple of questions, please, if I may. So comments first, Chris. Firstly, really welcome the paper and inclusion of the progress made with the perinatal mental health services. My comment would be, if I'm understanding correctly, that this is a hub and spoke model. So in Perth and Kinross, you have a spoke, which has the mental health nurses, for example, as part of that team. And then the actual hub has the much wider range of psychologists, psychiatrists, etc. Is that correct?
That's correct, Sarah. Yeah, we have a dedicated nurse for P&K, and that individual sees individuals and then can refer them back into the actual hub if they require further input.
Perfect, thank you. My second comment was just on your explanation under the key challenges and how you're looking at alternative workforces. And it was just a point of correction, please. In your final paragraph, you talk about associate practitioners instead of registered mental health nurses. And I would suggest that we are not replacing registered mental health nurses with associate practitioners. We're exploring alternative career pathways for practitioners, because Band 4s, as we know, can either remain as Band 4s and that work at the top of their licence, or some may choose to go on and train to be a registered nurse as a future career option. So it's a point of correction in that language. Yeah, thank you.
Happy to change that.
Thank you. So my two questions then, please, Chris, was in the page 18, where you're referring to the development of advanced practitioner roles, there's the final sentence refers to funding having been revoked and therefore the services at risk, but I'm not really familiar with what's being described there. Are you able to clarify that, please?
So about 2 years ago, there was an agreement by NHS Tayside that advanced nurse practitioner role within P&K would be funded out of the medical budget. But we've recently been advised that that funding is no longer available. So that's obviously now creating a bit of a cost pressure for us within the system. And that's obviously been highlighted through the finance team as well.
Okay, thank you. And my final question is, when you'd said around the key challenges of recruitment, retention, winter pressures and finance, I was a little surprised not to see premises in there. And I'm saying premises in reference to your final paragraph on page 24, where you're talking about the crisis hub and the potential around the future financial stability of that model. So I wasn't quite sure that I was wishing to see premises as part of those challenges. So just interested in your comment on that.
Yeah, so I suppose the reason that I didn't put premises there, and I'm happy to amend the paper and add them if that's what people think's best, but the reason I didn't put premises there was because we have a red risk on the register for the Health and Social Care Partnership around premises, but that's primarily to do with the community care and treatment hubs that we have. The crisis hub, which I've made reference to, is a third sector organisation who have their own premises, who deliver from their own premises, and that's not really part and parcel of the Health and Social Care Partnership's risk because it's not our premises. But I suppose I can see where you're coming from regarding if it's part of the mental health wider family and there's obviously issues, then potentially that does need to be recognised. So again, I'm happy to be led on that one and I can easily put that in.
Thanks very much, Chris. Yeah, just keen to see that interdependency because actually the building up of the community resilience and teams, they actually need still a base or a location that they can call home. So premises is key. Thank you very much. Thanks.
Thank you.
Beth Hamilton.
Thanks, Chris. I'll not use your Sunday name. Thanks for the report. It's amazingly positive, which is great in this kind of environment that we're all our heads down in. But I particularly welcome the joint working with the mental health team development to try and look at how we can share staff, and particularly the Band 4. One of the things I was also really keen on is there's not a lot of evidence there about how much we are progressing, although it's written in there that it's a positive picture other than a couple of diagrams. What I was wondering about the KPIs that we've got as Appendix 2, which I acknowledge are not agreed yet and are developing, etc. But a lot of it is qualitative as well as quantitative information. I'm just wondering, are you developing the structures to get that feedback when you're doing all your engagement work and your work with the third sector? I know, having worked with the third sector in the past, they have a lot of systems where they gather quality information, etc. So are we trying to do that as we go along so we can build up this evidential base of qualitative information?
Yeah, so like I said earlier, we've been working very closely with the business improvement team who have been taking this forward. What I suppose it's worth noting that what we did discover, which was actually the catalyst for developing the KPIs, was although we're good at generating lots of data, and I'm not just talking about the Health and Social Care Partnership here, I'm talking about Pantayside, sometimes it's actually quite difficult to extrapolate out exactly what it is we want to see and how we know that we're making a difference. So that was almost like the embryonic thought that commenced this, and I can't take all the credit by any stretch of the imagination, because I know that Hamish Dougal had highlighted that this was a requirement as well, and then obviously we got together and started to do it. We've started to pull data from the local surveys that we undertake around patient satisfaction, and there's also the national surveys that are undertaken as well, and I know that Chris and his team have been helping to support that. But equally, we are mindful that some of our third sector colleagues are doing regular reviews of patient feedback because they have to for their feedback into the annual commission plan. And a lot of those organisations actually currently sit on the mental health and wellbeing strategy group, so they're having input into this as well. And once these have been officially signed off, this will be a standing agenda item on our mental health and wellbeing strategy group, so everybody there can see it and feed into it before it then gets reported back either through IGB or back into EMT.
Yes, that's great. I'm really happy to hear that, because I just, you look at all that KPI, the work to start from scratch to try and develop all these routes to get all that information. It's quite daunting, but it's already a lot of it out there, and you've acknowledged that. So thanks very much, and keep up the good work.
Thank you, Beth.
Colin.
Thanks, Chair. I might just reverse the order of my questions so that I can neatly follow on from Mrs. Hamilton's question. In terms of the KPIs and their measurability and the attempt to develop quantitative ones rather than qualitative ones necessarily, when would the boards, because I know they're noted as draft, when would the boards see actual performance data so that we could see, you know, year 2 is better than year 1 is better than baseline, or whatever else it might be?
So we're hoping to have a first proper formal reporting mechanism ready before the end of the financial year, because we just need to finalise 1 or 2. So the actual Appendix 2 that's in the paper, albeit that is 95% ready, there are 1 or 2 areas on that we just need to slightly change, and there's been 1 or 2 areas that we've recognised that actually that's not possibly correct on what we want to report on. So we're just tweaking that at this moment in time. Once that's been signed off, then we can start gathering the data and formally get a report back out.
If I could just come in support of that also, Chris, that the IGB should see that, or at least the Audit Performance Committee should see that as part of the annual performance report at the end of the year, and alongside similar performance reports for older people and learning disabilities.
Thanks. And just to follow up quickly, we were talking about just there about, on the same subject, we were talking just there about the patient feedback and the surveys, for example, that third sector do. Again, that can be, while that is while that could be deemed quantitative, it is based on subjective things. I was just wondering whether we're trying to develop actual, you know, objective measures of improved mental health, like. I mean, I could try and come up with some off the top of my head, but you know, can we fit in objective measures as well?
So I suppose, I mean, mental health's always, and again, I don't need to insult anybody's intelligence, far from it, but mental health has always been quite a difficult science, for want of a better word, to try and measure improvements. The improvements that we normally look at are things like improved waiting times, patient satisfaction, reduced suicide rates and self-harm rates, lower levels, depending how you view them, lower levels of prescribed medication, because it means that people are accessing more therapeutic and psychotherapeutic interventions. So these are the sort of things that arguably we would be trying to measure. But again, I mean, this isn't fixed in stone. So it's a recurring process whereby if we identify that there is one specific thing or 2 specific things that we can actually pull in as evidential outcomes, then we'll incorporate those in future reporting.
Jackie wants to come in.
And I think this is a key area where we need to build on the work that Chris has been involved in, and the teams in Jane's teams from a performance information perspective, and see the whole system. So some of the harder data that you're asking about, Colin, is more likely to be available at that strategic level around rates of admission, rates of readmission, length of stay, all of those kind of things. So we need to see the whole picture. So I can take that forward into the discussions with the strategic group that I'm leading at the moment. Mm-hmm.
Just to build on what Jackie has said there, I think one of the things that we can also support Chris Jolly and his team is with yourselves is to look at what's happening nationally around the development of that wider indicator set, given the impact of COVID, and also working with public health colleagues, you know, to do so. But we know we're not sitting as one HSCP. There are another 30 odd out there, and we need to understand what other HSCPs are developing and bring that back to support the work of Perth and Kinross.
Thanks, that's very helpful, and particularly actually, Chris, you did mention some there, I think some usefully quantifiable, maybe objective measures in terms of reduced prescribing, reduced crisis admissions or crises in actual fact. So that's helpful. Thank you. My other question was on the same point that Mrs. Dickey had pulled out or in one of her questions about the advanced nurse practitioner roles and the revocation of the funding from NHST side. Can I just be clear, is that revocation of anticipated extra funding, or is it revocation of funding for posts that already exist?
It's for posts that already exist. We currently have 3 posts, and I use that word loosely because they're not all currently filled because of again, going back to the recruitment issues. But we have 3 identified posts across Perth and Kinross, 1 for each community mental health team. And one of those posts was originally agreed to be funded by NHS side about 2 years ago. But now we've subsequently learned that funding is no longer available.
Thank you. Jane, you want to come in?
Yeah, I think to create just a bit of balance in the discussion. I'm not sure in respect we might have used the word revoked. I think at a point in time 2 years ago there was a real genuine wish to look at a change in the skill mix, to look at how advanced nurse practitioners can seek to address the problem with consultant recruitment. I think a number of things have moved on in terms of thinking around that whole skill mix and who can do what. The funding position for NHS side has moved on. We've got an inpatient mental health service that is significantly overspent. And this discussion needs to be taken forward in 2 ways. It needs to be taken forward as part of the financial framework for mental health that Jackie talked about earlier. But in the meantime, it needs to be taken forward as part of our own budget process. And that funding gap has been taken into our budget process and will form part of our discussions and our proposition that comes back to the IGB in due course.
Thanks. That was just exactly my next follow-up, Jane. So this is going to be part of our budget discussions and potentially requisition towards filling those posts. Thank you very much.
Did I see Maureen's hand there? Maureen.
I would just like to continue with what Colin was raising there about the funding for the ANPs. I mean, earlier on in this meeting and also in the meeting this morning, there was a lot of emphasis put on the use of ANPs, and upskilling them. And I'm really disappointed and gobsmacked actually to hear that the funding has been withdrawn, because surely this is the answer to a lot of the problems, the recruitment of, consultant psychiatrists and etc. But also the overspend that you were talking about may be partly due to the use of locums anyway. And surely if these upskilled ANPs can do, prescribing and, a lot of other things that they would normally do, surely it's going to save money in the long run. So I can't understand why, that has been withdrawn and who made that decision, because to me that's the answer to a lot of the problems, like upskilling these people, who are skilled anyway, but to upskill them so they can actually prescribe and do other things that the consultants do. And the other thing was, yeah. Yes, right, okay.
Thanks, Maureen. And in terms of what you described there, I couldn't agree more, but what I can do is reassure you that whilst there are funding discussions that are ongoing and that they will continue into the budget process for next year, that is not standing in the way of allowing the service to recruit to these posts if they are able to do so. So the funding, whilst Chris has noted it as a risk, is not preventing recruitment to the planned the additional ANP posts, and hopefully that will continue to be the case if we can resolve the budget issues.
Thank you. The other point I want to make was something that was mentioned earlier. It's saying that service users, regardless of how they present, would be given appropriate treatment. Now, I know that in the past, service users that presented and been under the influence of drug or alcohol have been turned away. Does that statement there now say that they will be treated regardless of the way they present?
That's exactly what that statement says, Maureen. So as I'm sure you're aware, there's been a lot of dialogue with Scottish Government. There's been a lot of meetings taking place, and one of the key recommendations from David Strang's report was around ensuring that everybody who required access to mental health services received it at the point of contact. So what we are currently trying to do is develop a service where we will have a single referral system to make it easier for referrers, but also to ensure that when somebody gets referred into the service and requires support and help with their mental ill health, irrespective on the level of severity, they will be seen by somebody, whether or not that is somebody from third sector or whether or not that is a consultant psychiatrist. They will not be bounced back to the referrer and then the individual is left without any form of support whatsoever. So that is the model that we're taking forward. There is already work in progress with our social care colleagues, and we're hoping to align with that work that's going forward just now, so we can ultimately reach a point whereby we've actually got something heavily embedded within our service.
Thank you very much indeed. Does that answer your?
I just, want to point out that what comes first, the chicken or the egg? Is it the mental health problems that causes them to turn to drugs to relieve the issues that are going on with them? Or is it the fact that because they are mentally ill, that they take the drugs in the first place? Or is it the other way about, the drugs can actually cause the mental health problems? So I think, it's been wrong in the past, to turn these people away because, they present with, that is when a crisis can happen and they should be dealt with. So I'm pleased to hear, and I'll be able to feed that back now that that's all changed and that they will be dealt with, if they turn up and, under the influence of drug or alcohol. Thank you.
Thanks, Maureen.
Thanks very much. Before we move to just noting the recommendations, just a couple of things for me. I wondered about the Audit and Performance Committee being part of the thinking around about the qualitative and quantitative data they may want. Just to say to Beth, who's the chair, is that perhaps the group may want to be working in partnership with Chris to help to formulate the performance criteria that they would wish to expand upon Colin's point earlier. So that's a piece of work I think could be done before you bring the final document back to us, Chris. So we might as well use the tools that we have around the board. And the other one I picked up on was a great progress around working with third sector, and I noticed that the funding had gone to PCAVs. Do we know who all the funded groups are that PCAVs funded that would be useful as pointers for people to be put towards in terms of the services they've provided? I certainly would like to expand our relationship with PCAVs if that's, I think that's highly desirable given their importance within the work that we do. Okay, thank you very much indeed. So the recommendations we can note both of them, the local and pan-Tayside developments in line with our strategy, and to approve its continuation and direction for year 2. We content with that. Okay. Thank you. That was a very useful discussion on the last item. My intention is to try and finish by as close to 4 o'clock as possible. I'm mindful of a lot of folk have to travel and it's dark and the roads aren't very good. So I hope you could all bear that in mind with your questions and comments as well, he said, hopefully. So thank you. And I also want to leave time to say proper goodbyes to Jane as well. Okay, that takes us to the Strategic Planning Group minutes and update. Who's leading on this, Jackie? Jackie's going to lead on this.
Yes, thanks, Chair. I'm happy to pick up on that because we have apologies from Zoe Robertson today. I suppose the minutes that you have at item 7.4 speak for themselves. They're very full minutes and set out the second piece of work, the second of 3 sessions on the piece of work that's been carried out on and a self-assessment around engagement. And you also have a report from that in here at page 35. It starts at page 35 of the outcomes from that session. And at the same meeting, there was a presentation around the review of strategic commissioning plan, which I addressed in my update to you at the start of the meeting, and the proposals to take that forward. There's an ambitious target in there about bringing a draft revised plan but to the group in January. I think that's probably a bit over ambitious at this stage, but we'll see how that transpires. And the meeting on the 29th of October, 29th of November was unfortunately cancelled. So a new session will be set up to complete the third session of the self-evaluation exercise into the new year, and hopefully IGB members will be able to take part in that. Thanks.
Thanks very much indeed, and I'm grateful to Zoe for pulling this information together. And I can see quite a lot of positive things coming out of these minutes, particularly the work programme that you've been going through, and also I'll be interested to know in future the co-chair arrangements that you've been talking about earlier on in your previous update. So questions around the strategic planning group. Colin.
Thanks, Chair. It was just to confirm with the Chief Officer that when we're talking about the refreshed draft of the strategic commissioning plan, there'll be a session for IJV members to allow us to input into the direction that takes.
Yes, that would be correct. Thanks.
Do you have any more questions? Oh, Martin.
How do you select the community representative? How do you reach the hard to reach groups? How do you reach the isolated groups? How do you reach the groups with disability, loneliness? How do you reach these groups to inform the production of the plan?
Jackie.
Thank you. I think our public partners may want to comment on that. I know that Sandra made a comment earlier about the role that you're taking in raising the profile of the IJB. But within the Health and Social Care Partnership, we have a team of engagement workers who, in fact, I think there's 3 + 2, so we have 5 engagement workers who are very much at the heart of frontline service delivery and engaging both staff and people on the ground. So that hard to reach or hard to hear voices are certainly being picked up through the engagement workers who are also in attendance at the strategic planning group. There is a strategic, there is an engagement strategy that was approved a considerable number of years ago for the health and social care partnerships. I would suggest that that's something that what will fall out of the self-evaluation that you see here is a need to refresh that and build on the what's next and what are the next steps that people are raising through the self-evaluation exercise, Martin. So that's certainly something that needs refreshed and updated in the future.
I'm glad that it's got to be meaningful engagement, because the engagement to a lot of people means a lot of different things. A lot of time the engagement is about we're coming to tell you what's going to happen. Where in fact it's no, we're engaging with you, you tell us what would make your life easier.
Thank you for that. Maureen?
Yeah, I was just going to say I totally agree with what you're saying. The public don't want to hear what's going to happen. They want to feel that they are meaningfully engaged and that they can have input into the services that are affecting their lives and that. So, you know, at the moment, you know, Bernie Campbell and myself are the unpaid carer reps, and Ian and Sandra, they are the service user reps, and we attend meetings and that, but that's attending meetings. When there's consultations, quite often we do find that, you know, they've progressed quite a bit, and it's like an afterthought that there's consultations, that we've been assured that, you know, that will change. So hopefully it will, you know, and that going forward we will be engaging the public at, you know, an earlier stage in the consultations.
Bernie, then Sandra.
Hi, I think actually Maureen has just really answered the question. I was only going to come back to say that as the unpaid carer rep, both Maureen and I, through our connections with our Carers Voice group and other local groups, we do ensure that we meet with unpaid carers to you know, find out the things that are affecting them and what can be done to improve things. So yeah, thanks very much, but it was really just exactly as Maureen has said. Thank you.
Sandra?
Yeah, thank you very much. Yeah, and the point made is a really good one. And you know, how do I think we're never sure that we're engaging with everyone that needs to be engaged with. And that was, I guess, part of the rationale for setting up the reference group, which I think the supported by the community engagement team that Jackie mentioned, and they, you know, without them it would make the work that we do much more difficult. But I think there are maybe 50 individuals and organisations that are communicated with, and that's two-way communication via the reference group. But the kind of the striving to continue to widen our engagement is ongoing, and absolutely agree with what Maureen and Bernie have said about consultations. I think we've all been involved in, for example, the National Care Service consultation, and there's ongoing feedback that people are saying they've never felt so consulted with, but they're not absolutely sure that is really impacting outputs. And so I think that we do need to be careful that whilst, you know, very pleased to be consulted with and involved at a very early stage in discussions, that we do need to be mindful of incorporating outcome measures to whatever strategies are put forward. Thank you very much.
Thanks very much. So we're content to note the papers that have come to us. At some stage, you might want to think about how this work is presented. I think something more than a minute, but I think you might want some time with Zoe and the care reps and user reps to actually work that one through about how this should come and be reported to the IJB. So I'll leave that with you. Are you wanting to come in, Ian?
Chair, can I actually come back in? Sorry, I meant to say also very much aware of the work that Zoe is leading on, which was work to establish how users felt that they were being engaged with. So I'm thinking that that work at some stage will be presented back to the IGB.
Yes, the answer is yes, Sandra, but I think it's also about if we move to a co-chair arrangement with the strategic planning group, they may wish to take a different stance in terms of how they present stuff to the board itself. Okay, right, Ian, do you still want to come in? It's been asked. Okay. That now takes us on to Tayside Winter Planning Report. You've got a brief report, but you've also got quite a substantive appendix. It's a very operational document. So I'm going to ask Amanda to lead on this.
Thank you, Chair, and thank you for the opportunity to share the winter planning approach that you've described there. IGB members are asked to note the overarching Tayside plan. This is approved by the NHS board, and the NH board has a lead responsibility for developing the operational response in collaboration with the 3 health and social care partnerships and our Scottish Ambulance Service as partners, and we agree collectively the approach in terms of winter planning. The paper would normally come forward in October, but due to the system pressures and the impact of COVID, this has been delayed, and apologies for this just coming to the board just now. So to focus on our Perth and Kinross plan, our focus and approach in terms of winter planning is the right place, right care, right time, avoiding admissions where possible and ensuring we can arrange rapid discharge from hospital where it's safe to do so. From a Perth and Kinross perspective, we've been working on our winter resilience approach since July. So although the paper's late coming forward, we've been working away at this for quite some time. Alongside this, we've been working on our strategic improvement work around discharge without delay, in which we've made great progress. One of those areas was around opening a frailty unit on the PRI site, and we're happy to see that that opened on the 14th of December and is functioning fairly well at the moment. We're just working through with the team. Planned date of discharge was another element of that, and we've now embedded that across Perth Royal Infirmary and into our community hospitals with further improvement work going forward. And that's just part of our ongoing improvement plans that are in and around that. Alongside this, we've developed our hospital at home model, which we're in the final recruitment stages and the drive to make the model fully operational. And we've held a very successful session with our PRI acute colleagues and our clinicians to agree our clinically led approach in terms of discharge without delay and how we build capacity going forward. As part of our plan, the paper outlines our approach to how we build capacity, how we get ourselves ready for winter in terms of our business continuity plans being in place, how we arrange our festive arrangements and cover for making the services safe over that period, and then how we build our extra resilience into our plans. The resilience that we've built in this year is looking at care at home support, agency working, interim beds, increasing our community and resilience teams to build a flexible and able workforce over this period. I'll draw your attention to the paper. It does include some financial implications and workings, and note that 4.1 million has been invested over 2 years to support improved flow and winter resilience. This will also allow us to support the agreed trajectories for delayed discharges, which Jackie mentioned earlier in her paper, and this will allow us to focus on the specific areas in acute to maintain that capacity and flow. And I'm going to stop there and take questions if that's helpful, Chair. Thank you.
Thank you, Amanda. Questions for Amanda? David Illingworth and Martin Black.
Hi. During bad weather, roads get closed and communities get cut off. How can you identify the people who need carers in, and how do you get carers into them? You know, do you need the 4x4s or whatever?
Okay, thank you. So myself and Evelyn and Kenny can come in as well. We work very closely in terms of identifying who our vulnerable people are. So as part of our resilience planning, we would identify who's on our caseloads, who would be vulnerable, who wouldn't be able to get out of the house, etc., or we would have difficulty accessing the roads, etc. But there is, I'll pass you over to Kenny, because there is a resilience partnership that would help support some of that work also.
Yeah, each locality has its own resilience plan to cope with bad weather. We have lists of vulnerable people which are kept on shared sites with paper backup copies as well. They're refreshed on a weekly basis, especially at this time of year, and can be accessed in hours and out of hours. They identify the people that absolutely need to be got services to if roads are closed, etc. And we've got long-standing resilience arrangements with NHS Tayside colleagues and PKC colleagues as well, in terms of accessing 4x4 vehicles, prioritising road clearance, etc. And they were actually enacted just a couple of weeks ago. It wasn't so much snow, it's more flooding. There were a couple of folk we couldn't get to. So yeah.
Oh, thank you.
Can you talk about power outages as well, please?
Certainly, we do have plans in place for power outages as well, and we identify people who are particularly vulnerable if power goes down in terms of medical equipment, etc. And again, people with medical equipment that is basically at a risk of life if the power cuts go down, they have individual plans as well. But again, we have lists of people, and we can refine that down to postcode areas. And again, we're linked in with the likes of the power companies, etc. And we can prioritise people in terms of medical need, etc. They are in terms of either removing them to an alternative location, or in cases in the past when we've actually had generators and got them out to people's houses, etc.
And thank you, Martin.
Thanks, Chair. That's on page 62 of 84, and it's under the Annex 1. And I notice there's no inequality impact assessment being undertaken. But when we go to the strategic implications, that were inequality, inequity and healthy living. So why was there not an impact assessment? (62 of 84).
I think you're talking about the
Pending.
Yeah.
Sorry, I'm struggling to hear. Could you maybe repeat what you said, please? Sorry.
Page 62 of 84, under equality impact assessment, you've got no, but then when you go further down, you've got inequality, inequity, and living. So surely, if that's part of your plan, then there should have been an assessment.
Yeah, sorry. So the impact assessment's done as part of the Tayside plan, not as part of the Perth and Kinross approach, is my understanding in terms of the planning.
Thank you. Martin, you've hit on a really important point, and I'm conscious that you're new to the IGB, but we have in terms of our improvement plan, and the report that came previous, I think it was at the previous meeting. As part of that, we've recognised that there's a bit of a gap in our equalities duties in terms of reporting, and that's an area for improvement for us. And certainly, as we're moving into 23, you should see a much more strengthened approach to how we're carrying out the EQIs in relation to every report that comes to the IGB.
To Sally.
Thank you. It's just a quick query, and I have to confess that I know that you in particular are following what is NHS Tayside's winter planning, and also this is by no means an issue that is particularly in NHS Tayside. But I think it is an important issue that I'm always really disappointed that in all these plans there is nothing about how to support general practice. And I always find that really disappointing. We talk extensively of things like anticipatory care planning. We're really good at that in primary care. We talk extensively about complex care. We're really good about that in primary care. And yet recurrently, and as I say, it's not particularly this health board, primary care feels very much left out of these winter planning documents when we could actually be fundamental to making a change to actually what happens in secondary care.
Thanks, Sally. So yeah, I'm happy to take that back as an action and improvement action for next year. As I say, probably the planning that's been done, although we'll be planning from July, the Tayside paper was very late in coming forward. But I'm happy to feed that back into the Tayside groups as well in terms of how we might improve that connection. So thank you for that feedback.
Bernie, can you hear me?
Sorry, yes, I can hear you now. Mine was just a comment, thank you, on what Kenny was saying, obviously about the resilience team and the possibility of, you know, the power. I'm presuming then that part of that, you know, I know we're aware at the moment that there is the likely possible disconnection over January and February, that there's been information out from the SSEN for the winter preparedness, and I think that would have an impact particularly on people that are in very rural areas, as we would mention there, if you know, if they're on oxygen, etc., etc. So because I think they're saying it's likely to be happening in January, February, and that there is a rota out, etc. So I'm presuming that that's part of the planning. Sorry, did you hear me?
Yes, so sorry, Bernie. I'm just getting my mic switched on. Yeah, I mean, it's important to point out nothing's confirmed as yet, but it has been raised as a possibility, and there's a lot of planning going on at a Tayside level and at a local level to try and obviously mitigate any risks if, and I do stress if it comes to that. But you know, these will be planned outages if they do happen. I believe they'll happen for up to 3 hours at a time. There'll be specific postcode areas as well. So you know, if the time comes, we will have prior warning. And like I say, we're already starting doing scenario planning in terms of individuals and sort of wider areas as well to make sure we're prepared for that.
Okay, thank you.
And finally, oh sorry, Colin, and then I'll take Ian. Sorry.
Thanks, Chair. Thanks for the for letting us have sight of the overall Tayside winter plan. That's really helpful. And I know what was said about the timetabling of it and hopefully bringing it forward next year's bringing next year's plan forward in the sort of calendar year, so that if there are questions or feedback that can be inputted and incorporated. That'd be helpful. I haven't been through it in detail because I've seen quite a lot of these over my time, but just to follow up, I think on Councillor Illingworth's point and Kenny's response about that. Yesterday's Courier on the front page, and indeed yesterday's PA on the front page, there was mention of it, was about the call from one of the medical staff at Nine Wells to not go out at the moment because of the danger of slips, trips and falls on the icy pavements and whatnot. Obviously some people will have to go out. That might be because of appointments, it might be because of shopping, it might be because in actual fact they need somewhere warm to be during the day. And I know we've got lots of warm resilience centres sent up, warm hubs set up, not sent up. My specific question is, and I think the doctor said that there'd been an observed increase in the number of slips. Do our community planning partners chip into that? So council, roads maintenance partnership, Teesside contracts, in terms of if there's a spike actually going and making sure that an area is gritted or free from, people can access and egress properties safely.
Yes, is the short answer. Let's say through the local resilience partnerships, we are tied into fire, police, local authority, gritting departments, etc. And especially in terms of bad weather, we can ask for certain areas such as sheltered housing complexes, care homes, etc. to be prioritised.
Thanks. I mean, I think that sheltered housing complexes and so on are already on the sort of priority list. I was more meaning if there was a spike, like if there's lots of on the street. Yeah, exactly. Thank you, Evelyn. Putting it much more eloquently than I could. If there's lots of on-street incidents in a particular area, is there the ability within the system to respond to that outside or over and above the normal gritting routes for roads and the normal gritting routes for pavements?
I mean, again, that question would probably need to be put towards the relevant people in the council. But like I say, through the resilience partnership, certainly if we get any information that we are concerned about a particular area for whatever reason, it may just be reports of carers or clients of ours, we can then feed that in through the local resilience partnership and ask for that to be prioritised.
Colin, can I suggest that we find that information out and circulate it?
Yeah. Thank you. I think it would be. I mean, I think in general the possibility is still there. I would like to know that the procedures were actually in place and that this was happening, because on the street as well might not be outside somebody's home. It might be outside a shop that people frequently visit. Or in actual fact, I think there was I saw a response in one of my community council areas. On their Facebook page where people were slipping outside the GP surgery in Scone, and obviously people still have to get there. That's a high trafficked area that needs to be dealt with over and above what might be the routine.
Yeah, I mean, we have done this in the past, Colin. We've cleared GP surgeries and salted stuff. So I think there is an opportunity to do it once we're alert. We need to be alerted to it, obviously. But there are ways through either through the council or through healthcare or through Tayside contracts. We've cleared driveways and community hospitals and whatever. So once we're alerted to it, we've got different means of being able to get people to respond. So I think that's quite important, really. But those processes are still there. Last year I think we had to clear Beach Grove around the care and treatment service, and Tayside contracts came and did that for us. So once we're in that sort of business continuity, because that's what it's all about, then they will respond.
Okay, Ian, if you could be brief, please. It's my.
Oh, sorry. In relation to one or 2 points about the issue of being cut off, there's thousands of people in every part of Scotland self-cut off every week because they got a card and it runs out. That's it, dead, finished. And I was wondering if through the electricity companies and others, do they have a list of people that's in that situation? Because there are people cutting themselves off now, and it can be quite serious. Is that short enough?
Thank you. Actually, there is certainly my own experience, a disabled person. The power companies, if you've registered with them to say that you are a disabled person or vulnerable, whatever, then they will actually contact you. That's been my experience. But I'm not an expert on it, but I can say that's what happens. They're actually quite good at it.
I can also say from personal experience from living with my father, who is 85 plus, that they have a priority service for older people. And that would mean that you wouldn't be cut off, or you would be attended to in advance of everyone else in your street, for example, if it was a local issue. I'm also thinking that we have most of our very vulnerable people will have community alarm. So if there's an issue there in terms of their heating going off, lighting going off, or whatever, they will have access to that 24-hour support whenever they need it.
Okay, I'm going to take one final question. Sheila McCall.
Thank you, Chair. It was really a comment to endorse what others have said. Again, from my own personal lived experience, that people who are vulnerable with a disability that are registered as such with the electricity companies, I think there's a commitment not to disconnect their power, but it may not be the same for all companies. But equally, if there is a general power outage, there's priority. And in fact, you get regular updates as to what's happening to have power restored, and you have a separate emergency number for support if you're concerned about power outages. So there are processes in place, and I would like to think that through our social workers and through our other community engagement officers, that those people who are in those at risk groups would be aware of it, and would know that they should let their electricity providers know what their status is. Thank you.
Thank you very much indeed. So moving to the recommendation, we note the overarching Tayside winter planning report and the whole system collaborative approach taken in preparation for the anticipated winter challenges. And we encourage that way of working for quite a lot of other work as well. Thank you.
Thank you, Bob. I am pleased to present an update on the development of the Integration Joint Board's budget for the 3 years to 2025-26. Based on current assumptions, you will see in the paper that's been circulated for today, a recurring gap of £10.3 million is anticipated over the next 3 years, driven largely by the unprecedented scale of pay and price pressures, in particular across social care services, which at this stage is not expected to be offset significantly by Scottish Government funding. Our partners, NHS Tayside and Perth and Kinross Council, face an unprecedented scale of financial challenge, and there is minimal opportunity for partner investment in our services over and above the funding being passed through from Scottish Government. To remain financially sustainable, our focus must be twofold moving forward. On one hand, we must maximise all opportunities for increased efficiency, integration and redesign. And indeed, in the past 4 weeks, the executive team working with staff have made significant progress, reducing the 3-year gap from the £10.3 million reported in the paper circulated to a figure of £9.3 million. So progress is being made. Further focus is now being given by the executive team moving forward to maximising the benefit from the significant investment that's been made in this financial year, particularly in older people services, to ensure a reshifting of the balance of care away from bed-based services and the setting of clear and challenging trajectories for reducing admissions, length of stay and levels of delayed discharge. Because if we can do that, we can significantly reduce the planned additional costs in the budget for increasing our bed base on the back of the current levels of demand over the next 3 years. That's not going to be easy, and as been noted already, older people are being admitted with increased frailty in greater numbers with more multiple conditions. So there's no easy fix, but the financial resources are in place and we should be able to see improvement in our performance that should lead to reduced costs. Unfortunately, however, that in itself is unlikely to be enough. And if the IGB is to live within its means, difficult decisions will be necessary. And there is every likelihood that the IGB members will have to oversee the contraction to some degree of its strategic commissioning plan.
And it's crucial that in making those difficult decisions that we and officers provide strong articulation of the potential impact of these difficult decisions on equalities, on workforce and on outcomes. And I know the executive team are working hard to bring forward executive summaries to support that decision making moving forward. A key challenge will also be ensuring strong communication with our staff and with the wider public in the coming months, ensuring there's a clear and honest narrative around the potential impact of future decisions, whilst providing reassurance that all that can be done will be done to minimise the impact on outcomes of our most vulnerable people across Perth and Kinross. The Scottish Government draft budget will be announced tomorrow, and as far as possible, a further short brief will be provided to members before the Christmas break, which will give you a sense of what I consider to be the implications of that on the figures that have been presented today. And 2 further IGB development sessions are being planned for January, in which to work through what that budget, what the implications of the budget announcement are, and the level of difficult decision making that will be required. Before finishing, just to pick up on Ian's point of earlier around investment in long COVID support and whether COVID reserves can be retained for that purpose. It is worth just noting as I finish up today that the expectation is that COVID reserves are passed back in full. We still, however, wait a formal letter from Scottish Government that sets out the legal basis on which that is being done, and that will be something that Donna Mitchell along with Mark will bring forward to you to ensure that you're comfortable that COVID reserves are being passed back. I would say though, Ian, in terms of spending any of that money for long COVID, our budget process gives the opportunity to bring forward improvements, increased capacity to any services across our partnership, and at this stage we have not seen any requests come forward for above the Tayside service that was mentioned earlier for any enhancement to long COVID support. I'm very happy to take any questions.
Thanks very much, Jane. Greatly acknowledge the work that you've put into this. Any questions for Jane, please? Ian, you can be as long as you like, Ian.
Thank you.
I'm his new assistant.
Yeah, it's just on that specific point of long COVID. I'm not surprised that there isn't much reaction at the moment to long COVID as a separate identifier in terms of funding. However, the work that's going on just now in various parts of the country, and when I mean that, Scotland, England, Wales, and Ireland, research that's going on in relationship to COVID, long COVID, I think that will end up in less than a year or so to a point where quite specific budgets will have to be laid out. I know of a person, not because of what I raised here, but one young woman who lives in Perth and Kinross. She'd been unable to work for 18 months. Her whole life has been totally disabled by long COVID, and she can't hardly breathe as part of it. And so there are going to be quite complex cases in the pipeline which will require. And so that's why I was raising it. And thanks for your answer. Oh.
Yeah, I think as Jackie said earlier, our AHP director are leading the way in terms of the long COVID. The deep dive into long COVID, there have been people on waiting lists waiting to be seen, and we've taken that on now locally, and we are doing a lot of triage around long COVID and getting a sense of how much we need a separate service, or because long COVID, it affects your lungs, it affects your heart, it affects your fatigue levels, all sorts of different services. So it's how much do we need to build a service, or can we get our teams skilled up to be able to do that? So we have a community respiratory team. I'm just thinking about the lady you've talked about. You know, if we have those details, we can see how we can get some support there. So I think it's important that it's, you know, we upskill staff as well, because it's quite difficult to, because we created a service across Tayside, but it was too small. So therefore it's how you use and wrap around our own integrated community services with that additional expertise. So I think there's something there that Angie McManus is leading on for us from Perth and Kinross and Tayside's AHP Directorate.
Martin.
Thanks for the report. And it runs through my head that there was an initiative from the government that start to appoint long COVID officer. And it runs through my head that maybe Fife's got one. It may well be, it's maybe been me having a bad night's sleep. Yeah. But I'm sure there was something in that. But the questions I've got, but I'm unsure being a new member on here, because I was involved in a risk share IGB. What is the difference here if you've got £10 million or savings, or is it £10 million over 3 years that you have to save? Can that be put on to the risk share? I'm unsure, because I'm not making sense to myself, so don't worry about it. But the IGB has got an ability to direct, right, or to provide direction. But can they provide or invoke direction to, say, a health board or a council who have their own difficulties, and there's no risk?
It's a really interesting point, Martin, and if I've picked you up correctly, I think how I would answer that is to say that the integration scheme that supports Perth and Kinross Integration Joint Board does go into detail, and where not in the normal budget process, we would go to NHS Tayside and Perth and Kinross Council and request an additional 10.3 million. We know that that money is not going to be forthcoming, and looking at the integration scheme, what that requires us then to do is contract our strategic plan. And what the contraction of the strategic plan means is difficult decisions about current service levels. So we can't direct NHS Tayside and Perth and Kinross Council to provide the resources we think we might need. The integration scheme is clear that where those resources are not available and we can't make savings to balance our books, we need to look at contraction. And that may be the business that we are in once we understand what the Scottish Government budget outcome is for us tomorrow.
Thanks for clarifying that. Yeah. It's strange to me, that one, when there's a risk here now.
Yeah, I understand.
Martin, and a lot of this is in the Jane's induction pack for new members, so you'll have the opportunity to see a lot of the detail within that as well. So, there's if you want to have a long daily discussion about risk share, then this is the IJB to come to.
And Donna Mitchell is the woman to give.
Thanks, Chair. Just a quick one. At 7.2, there was to be a meeting at the end of November with the 3 chief finance officers and NHS Tayside to share planning assumptions. I just wondered if that had happened.
That has not happened, and there were provisional dates in the diary. None of them have gone ahead. That was being organised by the NHS Tayside side of things, but hasn't gone ahead at this point. So I'll, in part of my handover to Donna, will be to consider when that meeting can be, to push for that meeting. there is an ongoing exchange of information. However, just the meeting itself hasn't happened.
Thank you very much, Jane. So we note the recommendations. I won't go through them all, but there are 3 clear recommendations about the progress made, the development of the 3-year budget. And we're asked the Chief Officer to ensure all opportunities for additional redesign and efficiency. And we're also asking the Chief Officer to develop a range of contractions that may be required to support delivery of financial balance over the next 3 years. Thank you very much indeed. Beth, are you there?
Yeah, sorry, Bob, you were on mute. We couldn't hear you. Are you asking me to come in now?
Please, thank you.
Right, thanks very much. I'll be brief. We had a very brief and focused meeting of the Audit and Performance Committee, so my feedback will be in a similar vein. We started the meeting off and finished the meeting off by acknowledging Jane's valuable input into creating this background to the meeting, to the governance framework and to the reporting framework. And just to reiterate, we'll miss Jane very much and thank her and her finance team for all the work that they've done in this particular area. We talked about the financial position, which we've just covered now, so I won't repeat. We looked at our annual performance report, which identified our performance, particularly with our benchmark group of similar areas in Scotland, rather than just simply within a Tayside context. We looked at our strategic risk around some of the main red risks, which are still ongoing around financial resources, workforce, viability of providers, capacity of floor, etc. And our finance risk has increased to 25. We also looked at internal audit, and the main discussion around internal audit at the meeting was around the primary care report, which there was a bit of confusion as to where it is, as it's gone to 3 different areas at 3 different times, and we were just getting clarity and where it fits in with Perth and Kinross. And certainly the feedback we had was that there was a desire for Perth and Kinross through Hamish to be a bit more involved in some of the discussions around this report. We then discussed our internal audit progress report with the Chief Internal Auditor, Jackie Clark, who just presented an ongoing report which was on timescale. The clinical and care governance assurance, we had a very different report from what had previously been there. It was much more focused, it was much more transparent, and we're also acknowledged that we're going to have a development event to try and look at the KPIs and how we report, etc. And I think, Bob, you mentioned at the mental health section that we could maybe be looking at something to support them. So I would anticipate we'd take that through there. And we looked at assurances and services and other hosted services in different areas. We do mental health, but how do we get feedback from other areas? And lastly, we noted that there will be a stepped increase in audit fees, which Sheila McCall had asked about at a previous meeting, and she was wholly correct that we got a surprise, or not so surprised according to Sheila, for an increase in those services. And it was a quick rattle through, and that's another quick rattle through, but I'm happy to take any questions or comments.
Okay, any questions for Beth? No. Thank you very much indeed.
Okay,
thank you, Beth.
Thank you.
So item 10, these are for information papers. The 10.1 is the Integration Joint Board Reporting Forward Planner for your information and for noting. And the 10.2 future meeting dates. Now we've just circulated, Scott, sorry. Can you just update us on the position of the future dates? I know that Colin and I have agreed to future ones for 2023 in addition to the ones we have.
Yeah, just to confirm, and apologies for the lateness in circulating the dates. We circulated these this morning, new to IGB members. They follow a similar format to previously in that they take place on Wednesday afternoons. So as I say, all members should have received these by email this morning. So if we're happy to agree these, then we can fully implement them.
Are we happy to agree these, Maureen?
I'm sorry. I'm looking at the updates on page 80, 81 and 82, and it's got mental health and wellbeing update, and there's no ticks anywhere of when it's just got to be confirmed. Have we any idea at all between now and whenever, when it's going to be? Page 82. Yes, Right. Yeah. Oh, right, sorry. I'll be ahead, sorry. Okay.
Right, and I'm assuming that we will take the opportunity between the refresh board meetings for the year ahead that we will plan in dates for these development sessions as well. That will answer that question, Maureen.
Yeah.
And I'm told that Val's working on it. Question from Lindsay.
Good afternoon, everybody. I just was wanting to check the dates that were proposed that was sent out this morning. Has this been going through the NHS Corporate Board for the Area Partnership Forum as well? Because obviously I would like to be able to attend both. So it's just a question. Thank you.
Bear with a second, we'll get someone to answer that question, but there usually is quite a lot of work put into thinking about those.
I think, Lindsay, we looked at the NHS board and committees. I don't think we did look at the partnership forum, but if we can have a look at that to see if there's anything we can do.
Thank you.
Thank you very much indeed. Well, thank you. Well, that brings the meeting to a close today, the formal business. I'd like to do now the fun part, which is the informal business of saying goodbye to Jane. And I have a little script here, which is on my phone. So you'll have to bear with me, but and it now says low battery, so that so it could be a very, very short.
Do you need a wee budget to sort that out?
I know, I do. I need a wee budget to sort it out. Well, actually, Jane, you've been with us forever. Actually, I mean, you were appointed Chief Fin Officer to the Perth and Kinross IJB when it was actually established in March 2016, and you were the first Chief Financial Officer for this board, and joined from NHS Lothian in a joint appointment by Perth and Kinross Council and NHS Tayside. And there is no corporate memory, apparently, of there ever being a formal IJB meeting held without you being in attendance. Maybe you want to correct that now to get the records. Was that one of the meetings I want to forget? Over the years, Jane, you've steered your way through the complexities of the Public Bodies Joint Working Scotland Act 2014 and our local integration scheme, and you've established financial government systems for the proper use of funding and resources delegated to the IJB. I think on behalf of the IJB, Jane, you've established systems of good governance and steered through audited accounts. And most recently, you've helped us to achieve a position of financial balance in 22-23. And I think from my other part here is that You've also led on the work to support the Audit and Performance Committee with various chairs over that period of time that you've been with us, and you work to develop governance and reporting arrangements to ensure that the IJB meets its statutory obligations, hence the reference to induction processes, Martin, thank you. Now, I think most people will know that she's going to move on to a new and exciting role as Chief Operating Officer with a highly respected national charity, which was called CHAS, the Children's Hospital for Scotland, the Hospice for Scotland, sorry, and she leaves the Perth and Kinross IJB in a very positive position. And I noticed that Chaz was in news this morning on the television. So, and one of the first things that come up for me as I was looking at this which was about money, so I thought, oh well, Jane's just the very person to help to meet this £15,000 extra a day. So I thought this is perfect for her. But I was also thinking about Chief Operating Officer, and I thought charities, fundraising, and then I thought that will require a new form of sartorial wardrobe in my experience at working within the charitable sector. And what I could think of were black cocktail dresses, reception, and also the need for posh new hats for royal garden parties in my experience. So I think that you need to ask for an expanded expenditure budget for all of this, because believe me, you'll be doing rather a lot of this, as well as directing charity with some real scrutiny from our current chief officer, I believe is a trustee of CHAS. Yeah, I know. So anyway, that should be fun for you. But really what I wanted to do was just thank you for all the work you put into it. I've always found you to be very, very supportive personally. I think a lot of us would echo that. And you've always given us time, even when trying to explain some very, very complicated figures to us at times. And I've greatly appreciated that. And I just really want to wish you well on behalf of the whole board and personally from me. I have a card here that I'm hoping other people will sign apart from myself. But I think we've got some something else to give you, Jane. This is, now you can either take this to your board meetings and hide behind them when you get to difficult questions. But thank you from us. So,
Wonder if I might take the opportunity just to say a few words. Thank you so much, Bob, for your kind words. Who knew it was going to be so difficult to leave? It's been a long journey over the last 7 years, full of highs and lows. And whilst I am really, really excited about my new role, I am finding it difficult to leave behind. And I think that is because of the people and the partnerships and the relationships that have formed. So I will miss everybody. But I think you probably all know that this has without a doubt been the most challenging role of my whole career, needing me to use every ounce of experience, capability and resilience along the way. But none of that would have been possible without the support of all of my colleagues and all of you board members along the way, but also my own family who have been on this journey with me. With the difficult times, I was just reflecting there, my children are now 22, 20 and 14. And at the time when I joined here, they were 15, 13 and 7. So they have very much been on this journey with me and know far more about the Health and Social Care Partnership than you would ever realise. But well, who knows? Actually, Evan, I would encourage them absolutely to come and work in health and social care in Scotland, to be surrounded by such committed, passionate individuals as I've worked with over the last 7 years. And I'd just like to take the opportunity to just quickly thank some of the people that I've worked with. I would like to take the opportunity to thank some of the past chairs and vice chairs that I've worked with who have built such strong foundations that we're all now benefiting from now. Dave Dugan, Stephen Hay, Linda Dunyan, Colin Stewart, Callum Purvis,
and Eric Drysdale, whose passion and commitment and support in the early years and in building up the IGB, as I say, have provided such a strong foundation. I'd like to take the opportunity to thank past Chief Officers Gordon Patterson, Rob Packham, who worked tirelessly to their own personal detriment to deliver on behalf of Perth and Kinross IGB, and who trusted me completely to deliver for them. They're not here today, but I'd like to publicly thank my fellow Chief Financial Officers in Tayside, Dave Berry and Sandy Berry, who without their huge support over the past 7 years, it would have been a very lonely place to be. Tayside is very, very lucky to have such good Chief Financial Officers, and they will soon be joined by Donna Mitchell, who is similarly excellent. To Jackie and my executive team colleagues, thank you. I hope that the challenge that I've brought, and I know, and Jackie said just in another speech, I know I have been challenging. I hope you know that that challenge has been, I know it was. It's just so deeply rooted in my desire for you and for all of your teams and for you to achieve what you want to achieve. I'd like to thank some of my own team. I'd like to thank Donna Mitchell in particular, to thank Mark, and to thank Chris Jolly, who have, Chris and Donna in particular, have walked the journey of integration with me together, and I know I leave a strong legacy and strong leadership of integrated functions. But lastly, I want to thank my fellow IGB members. I'd firstly like to take the chance to first of all thank my public partners. Sandra, Bernie, Ian, Maureen in particular, you've taught me the immeasurable value of listening to those with lived experience, and I'm grateful to you for the challenge and insight that you've brought to our meetings. I'm grateful to fellow members, and I never cease to be amazed at the different perspectives that you all bring to the IGB, the rich personal and professional experience that enable you to hold us to account in so many different ways. Thank you for the richness of your experience and for the respectful, insightful challenge that you've brought to the executive team and to me in particular. I wish you all the very best for the future, and I leave knowing that health and social care services in Perth and Kinross is in very safe hands. Thank you.